You're here with us, and that's very important. And also that you're here with your family, so you want to introduce your family members before you start. That would be wonderful.
Yes.
Bienvenido.
Muchísimas gracias. I'm the one who's honored to be here, and actually my talk is on reducing health disparities from San Francisco's Barrio to the world, and you'll get the idea of this. But what I want to do, the first thing I want to do is to thank El Centro, Francis Morales and Amado Padilla, who I think is the person who brought me to the attention of the group here. I also want to thank very much my father and mother. My father actually came from Peru. He immigrated 50 years ago, exactly last Saturday, which makes this really a very, very kind of symbolic thing for me that this happened. And of course, my mother, who's here, Clara Luz. I'll be talking more about her impact on my work later. And my wife, Pat, Marin Munoz. I met her when I was getting my PhD at the University of Oregon. We met in 1975, married in 79. And had Rodrigo and Aubrey, who are also Stanford graduates. Rodrigo from 2005, Aubrey 2008, and then she co-turned in sociology 2009. Both majored in psychology. And my sister is here, and my cousin Dora. My sister Martha and my cousin Dora are here too. You know, the way we do things, as you know, I mean, Latinos do it in a family, right? So when you get an honor like this, I mean, you got to share it with the family. That's the way it is. Okay, and then I also want to thank my professors at Stanford, Gordon Bauer, I was his research assistant in my junior year, and Al Bandura, who was my senior thesis advisor, and they were very important. So I want to share some of what I've done since I left Stanford. I left in '72, and I want to dialogue. So I'm going to try to go quickly through some of these slides just to give you an idea of what I'm doing, so you have some ideas of what one can do after one leaves Stanford. And I'd love to have your ideas. I'd love to respond to any questions you have, but also your ideas about what we might be able to do. Okay, so I began my life in Peru. We lived in Chosica, a town 40 kilometers east of Lima, the capital. And Chosica is on the eastern side of the Andes Mountains. Okay, on the western side of the Andes Mountains. The eastern side is where the Amazon is, right? Very green, lush, but all the clouds hit the Andes, and it's very dry on the western side. So this is the town where I grew up, Chosica. This is Rio Rimac, the Rimac River. We moved from Chosica when I was 10 years old, and my mother is the one who gave us the mission as to why we were coming, and I'll mention her words at the end of the talk. But we moved to San Francisco. This is a view of the Mission District in San Francisco, taken from, hi Jeannie, taken from my office at San Francisco General Hospital. My office is on the 7th floor of the hospital, and so I can see all the places where I grew up. We lived on 14th Street when we just arrived. Then I went to Mission Dolores on 16th Street. So somebody here, Rudy, I think, worked at Everett, which is middle school, which is right across the street there. Then I worked for PG&E for 5 years during the summers when I was going to Stanford. That's how I paid my way with that and scholarships. And now I've been working here at 22nd Street. So I've come a whole 8 blocks from the house. My mother, by the way, works here on 22nd Street too, at 22nd and Bartlett. She's still working. She's 81 years old, and she's still working, taking care of, it's for a preschool place. So she was a teacher in Peru also, so we are still doing similar things. Okay, and this is where I work, the Department of Psychiatry, San Francisco General Hospital. This is the hospital, and again, my office is on the 7th floor. It's a county hospital. It serves the mission and the whole of the city. And then this is just a quick view of the things I've done. Again, we lived in Peru from the time I was born in 1950, so I was born right in the middle of the 20th century. And we stayed there until mid-April. I turned 11 April 30th. And then I was at Stanford 68 to 72, my PhD 72 to 77. And then 6 days after I finished my PhD, I was working at San Francisco General Hospital, so back in the mission. I think that's one of the reasons that Amado probably suggested that I be considered for this great honor, because I've been working where I grew up, in the same Barrio, in the same neighborhood, right, of where I grew up after immigrating here. So while at UCSF as a professor, I worked in an inpatient unit for 6 years, but I began doing some studies, for example, looking at how TV could be used to reduce depressive symptoms in people. I started depression prevention research in 1980, began a clinic with Jeannie Miranda and Sergio Aguilar Gagiola, two fellows in a psychology training program that provided services in Spanish and English for the medical patients at the hospital. In 1993, we began the Latino Mental Health Research Program. In the middle of the 1990s, we began this work on Tomando Control de Su Vida, which is a smoking cessation program. And then in 1997, we began doing some work with the Mamás y Bebés project to try to prevent postpartum depression in women who are pregnant. And most of them were Spanish-speaking, 85% of them. And I've been doing work on internet intervention since 1998. And in 2004, we began the Internet World Health Research Center. And some of my trainees actually are here. Adriana Aguilera, who actually was at Stanford until 2004, and then Jan Lakin here, who is an honorary Latino. He's from Russia, actually. But he was a Berkeley undergrad who did his senior thesis with me, and is now on the faculty at UCSF. Jeannie Tsai, who's a professor here in psychology, also trained at San Francisco General, so I'm very happy to see you here, Jeannie. Okay, so some of the things we've done is we have a Latino mental health research program. I'm sorry it's not very clear here, but we have a website, go ahead, in which we have some of the manuals we've developed in Spanish and English over the years. Anybody can download these manuals, okay, and use them to do prevention or treatment, and some of them have been downloaded like 20,000 times, especially the Spanish language ones, because as you probably know, there are not a lot of materials in Spanish, okay? So some of the things we've been doing at San Francisco General is to manualize our treatment for depression. But one of the problems with this, go on here, is that there are some limitations to using traditional treatment. And let me explain why there's a limitation. Some of the evidence-based treatments, for example, cognitive therapy for depression, have been tested in the following format. 20 individual one-hour sessions to treat depression, okay? And it works very well. It works about the same as pharmacotherapy. But the problem with this is that one therapist working 40 hours a week seeing one patient per hour would only be able to see the equivalent of 2 patients per week, right? So that's 20 hours, right? So in a week you would see 2 patients, the equivalent of 2 patients. If you work 50 weeks a year, you would only be seeing about 100 patients a year. There are a lot more people who need care for depression, even just at San Francisco General Hospital. So this limits us tremendously. So in 1978, I published a framework that basically set up this grid. I like grids a lot. They help me to think. What the three of us who wrote this paper said is that 95% of the work for mental health care is treatment by professionals. This is where most of our work is. And in order to reach people, to reach large numbers of people, to reduce disparities, we need to go beyond that. We need to do prevention, we need to do maintenance, which means after people get better to keep them from having relapse. And then we need to have paraprofessionals, where people who are not necessarily licensed, but they're trained to do work. Partners like big brothers, big sisters, or peers like Alcoholics Anonymous. Paraphernalia, these all begin with P, by the way, just to make it easy to remember. Paraphernalia, electronic devices, gadgets, and so on. And now, we wrote this in '78, but at that time there were no computers, no personal computers. They began in 1982. There was no web. That began in the 1990s. But now we can stop doing things via the internet. And then, of course, printed matter, too. So this would be a way to increase our ability to provide services to people. Okay? Now, the World Health Organization reports that there are over 1 billion smokers, over 121 million people with depression, 76 million people with alcohol problems. We'll never train enough people to really serve all the people in need. And I'm still training people to do therapy and to do it traditionally, but I think we need to do that plus more. So here's one example of a television study. We wrote a book called Control Your Depression, and NBC filmed us teaching the ideas in the book, and then had it broadcast in the NBC affiliates throughout the country. And when they did this in San Francisco, I put together a band of students who did a survey before and after this, and found that for people who began with low symptoms, it didn't make any difference whether they watched the segments or not. But for people who began with high levels of symptoms, the ones who watched the segments actually dropped down significantly more than those who did not watch the segments. So this gave us, this was not a randomized trial, it was a naturalistic trial, but it still gave us an idea that you might be able to share these ideas, these educational ideas with people through mass media, that you didn't necessarily have to do, face-to-face kinds of interventions. So now we're doing stuff on the web. Google gave us a grant, which allows us to put up sponsored links for free. So here it says Dejar de Fumar. So if somebody enters Dejar de Fumar, they will get our link here. Deje de Fumar por la red, estudio gratis para dejar de fumar por internet de la Universidad de California. So it's a free study to stop smoking online by UC. And then they come to our website, and then they can get immediately our smoking cessation guide by just clicking there. They don't need to do anything else. But if they want to participate in the entire intervention, they click here, and then they can go in, and we have some surveys and things, and we do an intervention. And we're finding quit rates that are similar to that you find with a nicotine patch. Okay? So what's wonderful here is, and you can't quite see the red dots throughout here, but we have reached people all over the country. From my office on the 7th floor of SFGH, I've been able to reach people all over the US, in Spanish and English, and all over the world, including Peru, but also including India, China, other places, Australia. It is amazing what you can do. And so now we're starting to do this for depression. We have the Mothers and Babies course that's being run by Aline Barrera, who was a postdoc with us. We have a depression management intervention that Jan Lakin is developing. And we're also using other kinds of electronic adjuncts to treatment. Adrian Aguilera is doing a text messaging adjunct to CBT for depression with our patients. So this is the kind of stuff that I think we could do if we use our imagination. So adding to think globally, act locally, this third line, share globally, I think that's one of the kind of messages I wanted to convey to you, and to get ideas as to how we could do this even better. So here, look at the people that we can reach through the internet. Spain is our biggest customer with 34,000 people who've come to our site. The US in English is the first one. So these are Spanish-speaking countries, English-speaking countries. Notice this, India, our second biggest customer. So you can reach people with different cultures, all the way around the world. I titled this thing about disparities, and I just wanted to mention to you why I think we could do something to reduce disparities using these media. If you look at English and Spanish speakers in our studies, you find that English speakers, the green bars here, are more likely to use a nicotine patch or nicotine gum or bupropion, Zyban, than the Spanish speakers. And Spanish speakers are much more likely to tell us, 60% say they haven't used anything to stop smoking before they come to our website, compared to 30% of the English speakers. So Spanish speakers are less likely to have had access to these things.